We continued discussing Jena and Worsham's random acts of medicine. This is the third part of our interpretation. This book discusses some very subtle effects in healthcare. I feel that studying these effects can be considered a luxury because these small signals are only recognizable when more significant influencing factors are normal, such as good medical conditions, patients with insurance coverage, competent doctors, and effective medications. Moreover, you need very detailed yet easily accessible data for this purpose. These studies are like adding flowers to the tapestry. More advanced pursuits than the average person's concerns about healthcare. Yet, they are relevant to everyone, describing the complexity of the world and the helplessness of knowledge. Often, despite our best efforts, some questions remain unanswered. But we can still appreciate these studies, some of which resemble solving a mystery and are commendable. To the point, this section is the swift and the slow of medical interventions. Imagine an elderly person experiencing sudden chest pain, possibly a heart attack, prompting a call for an ambulance. In an orderly city, traffic automatically yields for the ambulance, and citizens willingly give way. For example, in Boston, ambulances usually reach the hospital within 15 minutes of leaving a patient's home. Swift responses are undoubtedly necessary, but how necessary? We need a quantitative study. Of course, you can't conduct a controlled experiment, deliberately delaying the response for one group of patients. Natural experiments become the solution. During the Boston Marathon, Jena identified this as a perfect natural experiment. On marathon day, the city experiences traffic restrictions. Routes that were open before are closed, and even accessible paths become slower due to the crowds. By comparing the treatment outcomes of patients having a heart attack on marathon day and non-marathon days, we might understand the impact of ambulance arrival times. This idea seems straightforward, but questions arise. Why specifically choose marathon day? Why not compare the treatment outcomes and ambulance arrival times for all cases directly? The reason is the lack of randomness in such grouping. Perhaps some patients reach the hospital faster because they live closer, and their proximity is due to better economic conditions. Better economic conditions might indicate better health. If healthier patients are inherently more likely to survive a sudden heart attack, how do you prove the impact of ambulance speed? These potential interfering factors are called confounding variables in statistics. The distance a patient is from the hospital confounds the relationship between ambulance arrival time and survival rate. Sure, you could statistically examine all conceivable confounding factors, analyze their interference with the results, and carefully eliminate them. However, that's cumbersome and not entirely accurate. The best method is a randomized experiment. Using marathon day as a natural experiment's advantage is that it's a fallen from the sky factor unrelated to a patient's condition. To exclude the possibility of people having heart attacks due to participating in the marathon, researchers limited the data to cases of patients aged 65 and above. However, this is still a hypothesis. To ensure the correctness of these, as expected, researchers needed meticulous analysis. Jena and collaborators investigated 11 marathon events over 10 years in the United States. They compared patients who had heart attacks or cardiac arrests on marathon days with those who experienced similar events on non-marathon days to examine differences in outcomes. Defining a control group is crucial. Which patients not experiencing an event on marathon days should be selected as the control group? It's vital to ensure their conditions are as similar as possible to those on marathon days. Considering that traffic conditions vary each day of the week, researchers decided, for example, that if the marathon was on a Wednesday, the control group would consist of patients experiencing events on Wednesdays 5 weeks before and after the marathon. They identified 1,145 patients who had events on marathon days and 1,174 control group patients who did not. The average number of events per day was remarkably close. This is crucial, indicating that hosting a marathon did not increase the number of heart-related events in a city. Furthermore, the age, gender, race, medical history, and other indicators of the control group were very similar to those in the marathon group, making it a nearly perfect natural experiment. Would patients experiencing events on marathon days refrain from calling for help due to the anticipated traffic congestion from the marathon? No, the cases showed they did not avoid seeking help. Could some doctors volunteer for the marathon, leaving essential surgeries undone, resulting in decreased medical conditions? Researchers carefully compared the treatment processes of patients on marathon days and non-marathon days, finding no difference. Could patients be diverted to different hospitals due to traffic on marathon days, missing out on necessary treatment? No, patients were still sent to the intended hospitals. All these examinations were conducted to ensure the cleanliness of the research results. Now, the final results can be discussed. On marathon days, among patients experiencing heart attacks or cardiac arrests, 28.2% died within 30 days of hospitalization, while the death rate for similar patients on non-marathon days was only 24.9%. The only difference between these two groups was the ambulance transfer time. On marathon days, due to inconvenient road conditions, ambulances took an average of 18.1 minutes from the patient's home to the hospital, compared to 13.7 minutes on non-marathon days. In other words, a 4.4-minute difference in ambulance time led to a 3.3 percentage point increase in the death rate. Researchers also considered cases where ambulance routes were unaffected by road closures on marathon days. They found that the death rate for these patients was not significantly different from the control group. Only by reaching this level of analysis can researchers be certain that the 3.3 percentage points were indeed due to the ambulance's influence. This is akin to an additional death for every 30 people. It appears that every minute is crucial for heart attacks. Clearing the way with sirens and everyone yielding is necessary. Researchers seized the opportunity provided by this "fallen from the sky" scenario, employing highly detailed data and cautious analyses to conclude that faster ambulances lead to higher survival rates for heart attack patients. The 3.3% effect doesn't seem particularly surprising. You might wonder if it's worth it. It is. Only by reaching this level of rigor can your conclusion be trustworthy. This is the difference between scientific research and engaging in keyboard politics. Let me provide another example. Someone examined 100,000 cases of out-of-hospital cardiac arrests in the United States. They found that if someone on the scene performed basic life support, the survival rate was 11.2%, whereas waiting for a doctor to arrive and perform advanced life support resulted in a survival rate of only 7%. Can we conclude that performing on-the-spot cardiopulmonary resuscitation, CPR, is an effective intervention based on this data? Not really. Perhaps the reason someone received immediate CPR was because they were surrounded by people who knew how to perform it, residing in a high-income community. However, living in a high-income community might also suggest better health, creating a confounding factor. This problem lacks a large-scale randomized experiment like the marathon study. Sweden conducted one such experiment, recruiting thousands of CPR-trained volunteers. The study found that if a volunteer was within 500 meters of a cardiac arrest, they would be immediately notified by phone to perform CPR. The survival rate for the group with volunteers was 11.2%, compared to 8.6% in the control group. Is that conclusive? Not quite. The sample size was too small, and the data did not reach statistical significance. Thus, scientists couldn't draw a conclusion. This illustrates how challenging it is to obtain a strict conclusion in medical research. Therefore, when researchers adhere strictly to academic standards to draw conclusions, even if those conclusions sound strange, we should take them seriously. The American Heart Association and the American College of Cardiology each organize an annual conference attended by over 20,000 of the most important heart doctors nationwide. This serves as an excellent natural experiment because if doctors attend the conference, surgeries cannot be performed. How much impact could this have? The results were unexpected. Researchers treated patients admitted during the time doctors were attending the conference as the experimental group and those admitted during normal times as the control group. They examined 200,000 cases between 2002 and 2011, discovering that the event of doctors attending the conference increased patient survival rates. Heart failure and cardiac arrest are both high-risk heart diseases, usually requiring immediate surgery. The death rate for heart failure patients within 30 days of admission during non-conference periods was 25%, while during conference periods, it unexpectedly decreased to 17%. For cardiac arrest patients, the death rate within 30 days during non-conference periods was 69%, compared to 59% during conference periods. Of course, this study involved extensive efforts to ensure the data's cleanliness, which we won't delve into. After eliminating various possibilities, the most reasonable conclusion is that some surgeries might be better left undone. This is understandable because heart surgeries are major procedures and inherently harmful to patients. Sometimes the benefits of surgery may not outweigh the harm it causes. However, when doctors see a patient in need of treatment, even without considering any personal interests, there is a strong urge to perform surgery. This is a widespread social dilemma. Wanting to do something when sometimes it's better not to. The book also discusses a more peculiar study. Ambulances come in two types. One providing basic life support, where emergency personnel can perform only CPR, aiming to transport the patient to the hospital. The other type provides advanced life support, with a professional doctor on board capable of performing emergency operations such as intravenous injection, electrocardiogram, or inserting a breathing tube, enabling early treatment on site. So, which is better, an ambulance providing basic or advanced life support for transporting cardiac arrest patients? The statistical results showed that the survival rate for cardiac arrest patients transported by basic life support ambulances was 13.1%, while for advanced life support, it was only 9.6%. Surprisingly, basic life support seemed more effective than advanced life support. Is it because only severe cases are sent to advanced ambulances? No. Researchers only examined patients with similar symptoms, and the conclusion was that when patients were transported by basic life support ambulances, the survival rate was higher. Is it because doctors in advanced ambulances' on-site interventions somehow harm the patients? No. The data indicated that on-site interventions improved the survival rate of cardiac arrest patients. So why is basic life support seemingly better than advanced? We don't know. If you can scientifically find the reason, you might publish a significant paper. This part of the book tells us that assisting sudden cardiac patients must be swift. However, whether or not to perform surgery seems to require caution. We say, seems, not because the research conclusion is weak, but because the conclusion is somewhat counterintuitive. Even more counterintuitive is that basic life support ambulances appear more effective than advanced ones. Would you advise dispatching basic life support ambulances more often based on the study's conclusion? Is more medical treatment always better, or is less sometimes better? Is it better to perform surgery quickly, or is a slower approach preferable? Sometimes, all we can say is, we don't know. Not knowing is also a good answer. It's much better than blindly taking action at any cost. We can only wait, preferring to wait for natural experiments. In the next section, we will discuss the Hawthorne effect.
If you feel there is value in this, please like, subscribe to this channel, and leave your thoughts or suggestions in the comments section. Let's grow together and read more good books.